Hey, Dr. Blake here. I posed an interesting question on my social media today, and I want to just pose it here and talk about it quick to kind of give you a couple of ideas about pain, chronic pain, um, and a couple of things that might be in the way if you're experiencing that, in the way of you finding some solution. So the question I posed was, if you have two people that have had x-rays of their knees and they both have bone on bone, there's like no cartilage left. You have one person who doesn't have any pain at all. They don't even know it. And they're just like, oh wow, they said I have bone on bone, but they wouldn't know otherwise. The other person has knee pain that alters their daily life considerably. I mean, it affects how far they can walk. It affects whether they can get up off the floor or down on the floor with their grandkids or their kids. It's always there. It's always something that's kind of in their way of them living their lives the way that they want. Um, why the difference? They both have bone on bone, right? I think this is an important example because it just illustrates that there are many different causes for pain. There are many different reasons why it could be there. And especially with imaging, relying on an image, it can be helpful, but a lot of times it can get in the way because then we blame what we're experiencing on because we were able to see something on the image, and um, that can be a little bit of a box that it can put us in. It can kind of keep us stuck because then if we think my knee pain is from this bone on bone, we're likely to not think there's anything we can do about it, which is not true. So just another example of the similar kind of thing, someone with low back pain, it's not recommended in most cases with people with low back pain to get an MRI. People used to do MRIs a lot. Well, what we found out was there's a lot of people that walk around that have bulged discs. Some of them don't have pain, some do have low back pain. Actually, the low back pain doesn't usually have anything to do with the bulged disc. Unless you see on imaging that it's, a disc is pushing on a nerve and you have symptoms right along that nerve, that's a different story. But most of the time, it's not really helpful to get imaging. So again, this illustrates that we have different reasons that we can have pain. And so first, if you're watching this and that has been you and you've had some imaging, what you're seeing may be contributing. Don't let it put you in a box. Don't think that there's nothing you can do. So I want to give a patient example. A recent patient of mine came to see me, had a car accident a number of years ago, and from that has a nerve that's being pushed on by a disc. It's being impinged. And some symptoms along that nerve, like down the sciatic nerve, all the way to the foot. Well, what's interesting when I'm examining this patient for the first time is that I can push so many other places around the area and distant places that hurt so bad on this patient that don't have anything to do with the nerve that's involved. And what's really interesting is where his back pain is the worst. It's debilitating to this person. I can push at a distant place. I can push down on his SI joint, or the sacroiliac joint. It's where the sacrum and the pelvis come together. I can push right along that, not very hard, and that is excruciatingly painful for the patient. And it actually recreates the pain in his back. He feels the pain in his back in that horrible spot, but I'm not anywhere really close to it. So, again, if I can do that and I'm not doing anything to the nerve, but the patient's saying that's my pain, that's really interesting. So it's important to have someone with the skills to assess some of these other reasons that you could have pain, because those reasons can be addressed. I'm not going to change a pinched nerve if that's really there. And that may be playing a part in what this patient's experiencing, but there's lots of other reasons this patient has pain, and I can address those. So it's just some other things to think about, okay? Myofascial pain syndromes are really common. Fascia is the connective tissue in our body. It goes underneath the skin everywhere in our body. It goes around every muscle fiber, nerve, artery, every organ, and the fascia is connected to the whole body. Um, and it's this system that if you pull on it in one spot, it will, because it's all connected, it'll pull at a distant place. Um, and fascia is strong. It's got the tensile strength of steel. So this is very strong stuff. And um, if you have fascial restrictions, as I call them, um, you will end up with pain from those. Another reason that you can have pain is trigger points. Muscles, if you've ever felt these little knots in muscles and it really hurts to push on it, and maybe you can feel around sometimes and find them a lot of times up here in the traps. If you push on one of those and you can feel it radiate up into your head up here, I don't get headaches very often, but if I do, it'll tend to be right over here, and man, I can always push around and find a trigger point that's radiating up there and creating it. So we can treat trigger points. We can do things in the visit to treat them. Maybe they won't come back, and we can do things to prevent them as well. Another reason that you can have pain is you can have small little nerve entrapments. You know, the nerves are going through all this fascia that I was talking about, and the nerves, they're popping out of that, and they're right under the skin, innervating. They're going down deep around the joints and everywhere else. So if there is any impingement upon those from fascia, you can get nerve pain. So you can treat the fascia that's tight around that, but you can also treat the nerves. Sometimes nerves, especially if they've been like pushed on for a long time, they can be misfiring or they can be overfiring over and over and over. So sometimes we just need to like break the cycle of the nerve firing and see if it'll like reset on its own. So maybe we break the cycle a few times, and then it resets, and all of a sudden we don't get this constant firing. And it's like now we address that, and the knee pain is a lot better. Doesn't matter that there's bone on bone. And other things that are important to think about that are connected to some of those ideas are our posture, how we're sitting, how we're walking, if we're doing any sports or running or anything, like what's the ergonomics of that. Those all play a really big role. So I just want to put this info out there because I want you to kind of think about that there's a lot that can be done and a lot that can be looked at, and you just need somebody with the knowledge of this stuff and skilled hands to be able to really assess all of the different tissues in the different places that might be contributing, and to then be able to give you a pretty holistic plan to address all these different areas. I hope this just enlightens you a little bit into some of the ways that I'm thinking about pain, and feel free to comment, ask any questions. I hope that this kind of gets you excited, especially if you're having chronic pain, that you might have some other options out there. Feel free to reach out and ask me any questions. All right, take care.